for the pediatric population. For this, let us see what are the age classification of pediatric populations. Okay, now very common word is there, very common sentence is very always use. This means is children are not just small adults. Just a minute. एक फोन करू પછી क्लास ચાલુ है મારો. हाँ हेलो हाँ okay, so very common word is that is children are not just small adults. That means what? It is not that they are just miniature model of adults. Okay, suppose adult which is normal weight is 70 kg, height is around 5 feet some inch, okay, and the body is of this that, and children are not like that, just they are just minimized model. There are so many internal differences they have, and therefore they are not just small adult. There are so many. I remember I have asked this question, explain this, children are not just small adult, and this word I asked for 10 marks in one examination. The reason is there are so many factors which are there, which we shall be seeing, and therefore we have to understand that what are the physiological changes are there, and with these physiological changes they can affecting the person. Okay, and therefore we have got variety of children population. So how we can define it, or we can classify it? There is a preterm newborn. Preterm newborn means there is around gestation period of 40 weeks, 25 weeks. Sorry, 40 weeks is a gestation period. Okay, that is when any birth is taking place, the normal number of weeks is there, that is 40 weeks has to be taken place. But if any child or any infant that get birth before 37 weeks, so only 37 or less than 37 weeks are there, then we'll call it as a preterm newborn. Okay, because again this 3 weeks average life is less. Then term newborn, that is the completed 40 weeks term completely, and then there is a birth, then we'll call it as a term newborn, and from the date of birth, that is day 0 to day 27, we'll call it as a newborn. Then next term is called as a infants and toddlers. So infants to toddlers we call them up to 28 days to 23 months. Okay, toddlers are basically who can walk briskly. So almost we can say 28 days to somewhere year and so is the infant, and 1 year to around second year, that is around toddler. Then next is term is children, which has got the biggest range actually, second year to 11th year. So around you can say 8 years span is there in that. And then adolescents are there, that is having age that is 20 years to 16 to 17 years or 8. Okay, so these are called as adolescents. So these all are coming under pediatrics. Adolescents are actually what we can say is a very they are borderline. They are neither adult nor children, and therefore again we have to take some of the things in very careful way. So this preterm infants is not a homogeneous population, as I told you. That is because depends, anything before 37 week they can be anything. So it can be 25 weeks gestation. They can be very small. See, normally body weight is around 3 kgs. Average weight is there newborn babies. Okay, but this can be even 500 gram newborns are there. Okay. So these 500 gram newborns which are around 25 week gestation or 37 week gestation, newborn can have weight of around 3 kilograms. Okay, so that means slightly even up to 40 weeks they are having average weight around 3 to 3.5 kgs are there. So accordingly, see, body weight is so much decreasing in as the gestation time is there. So what are the important considerations for that? So what is the gestational age? What is the postnatal age? Means after delivery, what is the age? so these organs are most of the organs are immature, so immaturity of all organ system, particularly of hepatic and renal clearance systems, penetration of medicinal product into CNS because blood brain barrier is not properly developed. Unique neonatal diseases can be there, particularly some infections are there because again immunity is not well developed. The rapid and variable maturation of physiological and pharmacological processes, which leads to the need to alter the dosing regimens frequently, particularly when chronic expense is there. Then next category is newborn infants. So they are more mature in the preterm because they are having complete gestation around 40 weeks, and body weight is again higher, that is around 3 to 3.5 kg. Then but the drug absorption, metabolic excretions are affected by many factors which apply to preterm infants also, and many examples of increased susceptibility of toxic effects are there. Medicinal products, there are many impacts are there. There are many examples are there. So this year you did not study drug like chloramphenicol, which is actually antibiotic. You will study it in third year. So that is causing Gray baby syndrome. Gentamicin causes ototoxicity, that is hearing loss it is causing. So these are some of the examples. Then next is there infants and toddlers, that is after this 28 days to almost it becomes 2 years. So they undergo period of rapid CNS maturation, immune system development, total body growth. So these are the phase of growth of these students. Oral absorption becomes more reliable because earlier it was not that reliable because only milk this newborn will be able to take. So now absorption is becoming more reliable because GIT is developing, acid is getting secreted likely. The hepatic and renal clearance continues to mature rapidly, so that by the year of 1 to 2 years, the clearance of many medicines that equals to or exceeds than that of adults. See, clearance is more in some cases than adults, but considerable variability in maturity because some children and some drugs, they have different activity for that, so it is individual variability is there. And next is children's. Okay, next group is that is after second year, that is when the child that becomes of 2 years to of almost 11th year, just before the puberty situation. So most pathway of drug clearance, they are mature. The clearance again is exceeding the adult values. Example is carbamazepine. CNS active medications may adversely affect children's development milestone because brain development is highest in that phase. The onset of puberty is highly variable and it occurs earlier in girls. In some cases it may be as early as 9 years of age, and puberty can affect the activity of enzymes that are causing metabolism of medicines, and dose requirement of some of the medicines, they may decrease. Example, theophylline dose will be less in these children. Then adolescence, as I told you, it is a borderline. This experience period of rapid growth. There is a continued neurocognitive development and sexual maturation. Medicines and diseases that delay or accelerate the onset of puberty can have profound effect on the pubertal growth spurt, like sex hormones, chemotherapy, they will all affect the hormonal activities also. Many diseases are also influenced by hormonal changes around puberty, like diabetes, migraine, etc. Adolescents are also assuming responsibility for their own health, and non-compliance can be a problem because when they are children, the parents can force them to take medications. When they become these young adults, because adolescent they are somewhere more trying to be independent, but they cannot be, and therefore they can skip some of the doses, or they may take it in wrong way. Then by that time some of these they may start recreational drugs like alcohol, tobacco. So because it was not there in children, so they may also impact in these people. So these are various situations, these are the various activities. We shall see in more detail what are the pharmacokinetic changes are there in that. Okay, so let us go the developmental changes which are affecting the drug disposition and the pharmacokinetics things. Now, what are the impact of that? Suppose first is a GIT. So, neonates and young infants, there is a reduction in the peristaltic movement. So, if peristaltic movement is reduced, then gastric emptying time is more. More gastric emptying time means drug will remain more in stomach and slowly go into intestine. Now, you understand that intestine is the most important place of absorption, because intestine provides more surface area and better absorptional criteria. Okay, so here, since the drug is remaining more in stomach, it will be going less in intestine. Now, here we are not using what is the impact on the absorption, because it will depend. The drugs which are getting absorbed from stomach, they will be absorbed more because the drug is remaining more in stomach, because gastric emptying time is increased. Okay, gastric emptying time, I told what it is. It is the time taken to empty the gastric content to intestine. So, gastric content is emptied, suppose in 10 minutes or 15 minutes or half an hour. Normally it is around 1 hour. So, when it is emptied in 1 hour, then what will happen? Drug will remain in stomach for 1 hour, okay, and then it will go to intestine. So, the maximum absorption will take place in latter phase. But if it is remaining, if it is increased from 1 hour to 2 hour, the drug will more in stomach, okay, and whatsoever impact it will cause by stomach, maybe acid impact because of the acidity, absorption increase or decrease, that whole impact will be there on that. Neonates, they are also having in the more intragastric pH, that is normally in adult it is pH is around 2 in the empty stomach, and slowly it can increase, but in neonate it is having more pH, that means it is lesser acidic. Infants having enhanced lower GI motility, so drug will be passing slowly from intestine. So, what is the implication? I told you what it is making. That is, if the drug is absorbed from stomach, then absorption will increase. Okay. Then, if the drug is absorbed from intestine, then it will decrease the rate of drug absorption. Its extent may remain same. Rate and extent was the viability, if you remember. Rate means how fastly drug is absorbed, and extent means how much, whether 20%, 50%, 80% drug is absorbed. So, extent may remain same, but rate can decrease. Then potential, there can be potential increase or decrease in the absorption of the certain medications. Okay, I told you why, because the pH will be affected, the emptying time will be affecting. There is a potential decrease in the retention of suppository formulation because decrease in the lower GI motility. So, what is the clinical implication? There is a delay in the onset of drug action after oral administration. There can be increase of the acid labile medications like penicillin, and decrease of the absorption of the weak acids, particularly like phenobarbital. In what case? Neonates. Because acid labile, why increase in the absorption? Because it is not as acidic as adults. Okay, you have seen the intragastric pH is more than 4. So, that means the acid labile substances will not be damaged, or they will be less damaged, because it is not very strong acid. Okay, and there can be decrease of the weak acids like phenobarbital, because acidity is less. So, if you remember that Henderson-Hasselbalch equation, pH and pKa relations, so in that case, those which are acidic drug, they will not be absorbed from the stomach. Then skin and mucosal surfaces, what will happen to them? Neonates and young infants, they will have greater cutaneous perfusion, enhanced hydration, and larger ratio of total body surface area. So, more percutaneous drug absorption, anything you apply by cream or like that, more it will be absorbed. Increase in the relative exposure of topically applied medications comparative to adults, because many times they are in case of adults, again clothing and etc., they have to go out, and because of that there is some difficulty in that will not be there in these neonates and infants. So, there will be increase in the viability and potential toxicity of the systemic absorption of the topical medication. Now, a very important thing is, most of the systemic topical absorption when we medications, we know that they are not intended for systemic absorption. We expect that they should work only locally and they should do it, and therefore they are comparatively more safe, because they will be working in that area and they will not go to whole body. But here because of that absorption can increase, and because of that, if the drug is toxic, it can cause toxic. Okay, so you have to decrease the amount of medications which are applied to it topically, particularly like corticosteroid, etc. You should be there. Then body compartment. You know what is body compartment? We have seen it earlier, that example, blood is occurring as then extracellular fluid is one of the compartment, then various tissues where the drug can go, they are acting as a compartment, and in that these are the places where drug will remain in variety of form, either free form or bound form. So these are various compartments which are very crucial, because the plasma concentration is related to the effect of the drug, and these compartments have big influence on the plasma concentration. So in neonates and infants, there are less fats, less muscle mass. Because of that, any drug which is going to fat, the drug which are going to muscles, that will be less because it is less. Therefore, there will be increase in the extracellular and the total body water spaces will be there. Okay, so fluid will be more. So drug concentration, if fluid is more, what will happen? The plasma concentration will decrease. But if it is not going to fat, it is not going to muscle, again plasma concentration will increase because fats are not available. So thus, because of that, there is an increase in the apparent volume of distribution for medication distributed to body water spaces. So it will go more in the water, okay, because water is more, and there will be decrease in the apparent volume of distribution that are bound to muscle or fat. So it will be nullified when these are two different activities are there. But the drug which are not going for the muscles, their volume of distribution will increase. If the volume of distribution increases, the plasma concentration will decrease because volume is more. Okay. So medications with high volume of distribution can be accumulated in the body and they can cause toxicity. But at the same time, because of the high volume of distribution, the plasma concentration will decrease and there can be lesser activity. The volume of distribution medication tends to be increased in the infants, which and while decrease to the adult level during the childhood. So slowly, example gentamicin, the volume of distribution will be more in infants, and then slowly, gradually it will reach to, or it will less towards adult one when they become children. So this is the drug like gentamicin, theophylline. Then plasma protein binding. Okay, these are the again important things. These are the parameters of distribution, if you remember. Body compartment, plasma protein binding, these are the distribution okay. Now neonates, they have decrease in the concentration of albumin and alpha 1 acid glycoprotein. So there will be decrease in the binding affinity, so protein binding will be decreased, therefore unbound concentration will be increasing, and therefore there is a increase in the free drug. You know that when there is a free drug, then it can show activity or more activity, or these drugs are also responsible for the toxicity because free form it is there. So there is a potential for toxicity in neonates, like phenytoin may cause it, increase in the toxicity. Differences in the plasma protein binding are not clinically significant beyond certain period. Then means in children there is no big difference. The drug metabolizing enzymes, like that is what is the activity of this metabolism. Neonates and young infants, they are immature and discordant patterns of metabolism. Children from 1 to 6 years, slightly apparent activity increases for some of the metabolisms. Okay. So in neonates and young infants, what will be the activity? There is a decrease in the drug clearance early in the life with increase in the apparent half-life. Children 1 to 6 years, there will be increase in the plasma drug clearance, like reduced elimination for specific pharmacological absorption, pharmacological substrates. Okay. Neonates and young infants, therefore, what will be the clinical significance? There will be increase in the drug dosing interval, or there will be decrease in the maintenance doses of phenytoin, theophylline. Why? Because drug is remaining in the body, metabolism is not happening. So if you give the dose similar to adult one, it will remain in body for longer period of time. It may accumulate. So you have to decrease the dose and you have to decrease the dosing intervals. Children from 1 to 6 years, for that they may need to increase the dose and or decrease the interval. Okay. depending on that, again carbamazepine, phenytoin, ethosuximide, and again in most of the children these are very common illnesses of this. Then excretions, neonates and young infants, there will be decrease in the glomerular filtration rate. Okay, then the active tubular secretion will be changing for first 12 months with adult values attained by 24 months. Neonates and young infants, accumulation of renally excreted medicines, and for active metabolites with decrease or plasma clearance and increased elimination T-half. Greatest will be during the first 3 months of the life. Neonates and the young infants, they increase their drug intervals and decrease the maintenance dose during the first 3 months of the life. So these are the various criterias. Now see some of the practical issues which are occurring. Okay. Okay. Logbook you wanted? It's not your logbook. I think I have kept them in that room. That Pukde or Anand must be having key of that computer room. You ask him? I have asked because some minister visit was supposed to be there, so I asked them to keep everything over there. Everything is going fine? Okay. So see what are the important medications which are given and what are the reasons. Okay. For 0 to 4 years, which are most important because they are more prone for infection, so antibacterial. They are prone for allergies, respiratory tract, you know, asthma, etc. Then you have to give them. Then topical corticosteroids for some allergic activities, or systemic corticosteroid maybe for asthma-like conditions or for such things, ophthalmic, NSAIDs. Then topical antifungals, fungal infections are there, emollients, analgesic, and GI drugs, because they are prone for again what we can say GI related problems. 5 to 11 years again antibacterial, because again they are prone for that. Respiratory almost same you will find, but here pain and other chances are more, so NSAIDs will just come up, okay, and other will be there. Then cough and cold will also be there. So these are basically medications which are required. 12 to 15 years what are there? These are various medications, almost same, but you can see now NSAID is gradually increasing to second place, because NSAIDs are required now, because sometimes pain or fevers and etc. will be there. So respiratory, analgesic, topical corticosteroids, systemic antihistaminics, etc. These are the drugs are given. So these are the age wise what is the requirement, which are the most required in the this. Okay. Now again another issues are their formulation, because if they are too young, you cannot give them tablets, so you have to give them in a drop formulation or solutions formation, which will palatable. Okay, because you cannot frequently go for administering injections to doctor. So these are there, and therefore these are various things has to be planned. Okay, accordingly the dosage format has to be made and the drug has to be administered. Then it is not advised to use for off-label or unlicensed use. Many administered in children use outside their term of product license. Example, they are license or indication or something else, and they are given for some other thing. These are called as a off-label use or unlicensed use. The drug, suppose there is a drug A which is approved for use in diabetes, but if somebody is using in some other growth case or some other conditions, then we call it as a off-label use, and it is not approved by FDA. So till that period it is called as a off-label use. Okay, so basically it should not be used, and okay, so this off-label use should be, as far as possible, should be avoided. Okay, then what are the pediatric regulations are there? Okay, So features of the pediatric regulations are there, that shows that uh, pediatric investigation plans should be submitted for pharmaceutical companies, agreed by expert committees. This is for clinical trials, what should be given, okay, and accordingly they should go for that. There should be an expert committee for that, that is expert pediatric committee, which will take decision on that. And authorized medicine will be only given. Off patent medications can also be given. We have seen what is patented and what are the off patent medications. So by this way one can go for the pediatric this one. Very important things are what are the pharmacokinetic changes it is making. This is very, very important, okay. So these changes and what is their impact on that. As I told you, this is a very, very important area, and you can have just information about this. So once the pediatrics are there, now the next thing is pediatric calculation. I'll go for the another one, how the doses are calculated. There are many formulas are there, okay, because important thing is most of the these, what we can say, these childrens are there. We know that they are not just small adults, okay, they are the having a unique feature, because of age wise they have different conditions. We have seen them in brief, okay. So in that condition, what should be the thing, how it should be given, okay. So for that the doses are given. And doses are given in a different way. These doses on the basis, okay, how the this drug will be acting, what are the features of the pharmacokinetics, and on that basis